Hi, this is Brian Kim. I'm going to share with you case number 217 in the best way to do cataract surgery series. This is a 3 to 4 plus dense lens, pretty dense, mature cataract. And you're going to see terminal chop, cross chop, mechanical fracturing techniques, and how I'm able to crush the lens with opposing forces, very confidently using the chopper to manipulate the lens, mobilizing the lens. And I'm able to do this by crushing the lens into smaller and smaller pieces. By doing it this way, I can reduce CDE. As a result, you'll have clear corneas post-op day 1. So I'm using the cotton tip to steady the eye, asking the patient to keep their eye still. I use a corneal marker, which will help me to center and size the rhexis. This is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You see this patient's eye movements are rather quick, and so I'm really very ginger around the eye with patients like this. Intracameral lidocaine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is a triplanar corneal incision. I'm asking the patient to be nice and still. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then controlling the eye with the cannula, I enter. These patients with real quick eye movements, you just have to be really careful around them, because as you approach them with an instrument, they might suddenly move their eye, and then you might scratch the cornea or something like that. So it's very important, especially when I'm doing the capsulotomy. I have 2-point fixation. I'm using the cannula to hold the eye still, as well as I have my rhexis forceps. And I'm using an Orlock technique to hold the eye steady, because this patient's, again, I don't trust them, and I don't want the eye to move when I'm doing the capsulotomy. So I puncture with the forceps. Yeah, so this patient's really not cooperating. The patient's moving their eye. And so I go ahead and stop with the cannula. So the patient is looking a little bit up. You have the Bell's reflex there. So I took the cannula out, but I feel like I have good control with the rhexis forceps. So I grab the flap. So I go around circumferentially, grabbing and re-grabbing very carefully. The nice thing about these microforceps, there's very limited OVD egress, and I'm able to rotate the forceps in my hands, which allows me to grab the flap at a variety of angles. But I'm trying to keep the rhexis size to match the corneal mark that I made previously. You can see there's quite a bit of density to the cataract. The visibility to the capsule is a little bit limited, but I chose not to use trypan blue in this case, and then we finish off the rhexis. This is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, which decompresses the bag, push the lens back down into the bag, loosening up the lens from the anterior capsule, and the lens begins to spin. So now the lens is nice and loose. Again, pretty dense cataract, irrigating the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize decimase trauma. You can see, again, the patient not the best as far as cooperating with keeping the eye still, a little bit stiff. First, it started with moving the eye around a lot. Now it's again a little bit stiff. 2-point fixation is important with these cases. Go ahead and remove the surface epinuchal material, and I switch to the dense cataract setting. I go to sculpt, and I'm sculpting, bevel up, a nice groove. Again, I don't make a super long groove either way. About 6 millimeters is fine. You want to just remove that central dense core. Just like an apple core, you want to be able to get to that middle part. I go bevel down now. I switch to quad mode. I place the chopper under the rhexis edge contra-incisionally. I fracture the terminal side, and as I separate, that terminal fracture point propagates all the way across, and now I have an effective chop, and again, bypassing the posterior plate phenomenon. I place the chopper around the right heminucleus, hooking the peripheral lens and crushing the lens in half, and that is cross chop. Placing the chopper around that first quadrant, fracturing that piece, lifting that fragment up with some vacuum, and then using opposing forces with the instruments to crush the lens into smaller pieces, and then emulsifying the lens piece. Once the lens pieces are small enough, I go ahead and eat those pieces, again using sparing amounts of ultrasonic energy and vacuum. Turning the lens, getting the chopper around that second quadrant, crushing the lens in a cross-chop maneuver again, lifting that fragment up, and then crushing it between the instruments and emulsifying the lens piece. The length of that chopper, the right angle of the chopper, is really the key for this technique. Again, those of you who watch my channel, if you try to do this with a different type of instrument that is not a right angle, and if it's shorter, you will notice that you'll have trouble. So it's not a limitation of the technique. It is the limitation of you have to have the right tool for the right maneuver, and so that's what you need. Turn the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip. The phaco tip is positioned deep in the bag, and I'm able to fracture the lens in half with another cross-chop maneuver. Perform the same maneuver around that third quadrant, hooking the peripheral lens with the chopper, crushing it against the phaco tip, and then that piece is also cut in half. Again, using mechanical fracturing forces to crush the lens pieces into smaller and smaller pieces, and then when I'm ready, I emulsify. Turning the fourth quadrant around, hooking the peripheral lens. It's turning a little bit on me because now the bag is nice and open. So I go ahead and just position it again with some vacuum, trying to rotate the lens, and then I'm able to crush the lens completely in half. Grabbing that piece with some vacuum, emulsifying those small fragments. And that's the beauty of this technique. When you leverage mechanical fracturing forces, you have complete control because you're using both hands to position around the lens piece, and then you can crush it. And you can do that in any position in the eye, because you're only using infusion pressure. You're keeping the eye inflated. You're not using vacuum, ultrasonic energy. It's completely safe. And so that means you can perform that maneuver anywhere in the eye, even if it's close to the posterior capsule. So I go ahead and start to remove the epinucleus. As I do this, you can see now the red reflex is coming into view. What a beautiful sight to see that nice red reflex. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. You can see there's not much cortex anyway. Try to remove the little small remnants of the cortex. Switch to polish mode, polishing under the rexus edge, removing the lens epithelial cells. Polishing the posterior capsule as well. Sometimes there's some fine wispy material. You want to remove that as well. I'm always mindful with these cases of zonulopathy when you have a super dense lens. And so as I am polishing, I'm always mindful to see if there's some zonulopathy. Using the polish mode provides me some more information on the zonular integrity. So again, using mechanical forces to crush the lens, as I was saying before, to hook the peripheral lens with a long chopper that's right angled, you're essentially acting like a hook. It's like a hook. You're able to pull lens pieces up out of the bag. I'm able to cross chop from any angle. As long as I position the phaco tip with opposing forces underneath, on the other side, deep in the bag, I'm able to effectively chop the lens. Again, I'm using the phaco tip as a chopping block. Pulsing BSS into the capsular fornix, especially in the subincisional area. And I like to use that cannula to do that. Again, it's a two-handed maneuver. It takes some practice to doing that correctly without, losing control because it is a bimanual maneuver. So I caution anyone who's going to use that maneuver to make sure that the cannula is nice and tight on the syringe, and just practice how you do that maneuver. You don't want to break the posterior capsule in the process. Go ahead and use the sweep to sweep underneath the rexus edge under the left and then the right side. And this is a single piece acrylic lens that's going into the capsular bag. I go in with irrigation off, activate irrigation, loosening the haptics off the optic, going underneath the lens, tilting it and rotating it, removing the viscoelastic from within the bag, repositing the optic back down, polishing under the rexus edge. As I was doing the INA, I could sense that the zonules were good, so we went with a single piece acrylic lens, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient, 3 to 4 plus dense lens, cataract. Again, if you did normal cataract surgery techniques with a divide and conquer, the CDE would be really high because you're really having to use a lot of energy to divide the lens. And you get worried about going really deep, because if you have to sculpt really deep, what happens? You can have the dreaded posterior plate phenomenon, a Pac-Man effect. If you went with horizontal chop, vertical chop, you would most likely have difficulty fracturing the lens completely in half in some of these cases. Again, some people are very good at those techniques and they do a good job, but it's really an indirect and, in my opinion, an inefficient way to disassemble the lens compared to this technique, which is terminal chop. Debulk the center and then fracture the lens from the terminal side by placing the chopper out to the equator like you would do with horizontal chop or double chop. Fracture the lens at the periphery. That means you're fracturing through the peripheral posterior lamella, and as you crack it, it starts to propagate all the way across into the subincisional area, and now you have two heminuclei. You're able to perform cross chop on the rest of the lens pieces. Again, cross chop is placing the chopper around the equator, and then I'm able to position the phaco tip deep in the bag on the other side of the lens and then crushing the lens by pulling the chopper towards the center. And why is this important? I'm not grabbing the lens. Remember, when you're doing like other chop maneuvers, they grab the lens with the phaco tip with high vacuum, holding it and then crushing the lens and then chopping the lens. I don't think that's the right way. I mean, obviously, I'm thankful for those innovators who developed those techniques. But now, as I've evolved as a surgeon, I've realized that's really not necessary. And it's actually going to be dangerous if you try to use high vacuum to hold loose lens pieces that are floating around in the bag. You might grab the posterior capsule. Don't use any vacuum. You're able to place the chopper around the lens in the periphery, place the phaco tip on the other side deep so that there's opposing forces around the lens material, pull the chopper towards the center, and it fractures the lens against the phaco tip. And you don't have to hold the lens with vacuum. The phaco tip is really there as a chopping block. It's just there to be in the way. So as the chopper is crushing the lens, it has that opposing force. And by doing it this way, you can hold that phaco tip at any angle. You don't have to angle it in such a way it's trying to hold the lens. So again, that adds to the versatility of what I'm trying to say on these videos. And so again, very efficient lens disassembly, terminal chop, and then leveraging cross chop, which I can chop at very different angles, and then crushing the lens pieces with opposing forces, breaking it down into smaller and smaller pieces, utilizing mechanical fracturing techniques, and then pulsing the phaco tip to remove the lens pieces. You saw this case had fairly low CDE relative to the density of the lens, and this patient's going to be having a fairly clear cornea after cataract surgery post-op day 1. And considering how bad this cataract is, these are the patients who give you the wow experience. These are the patients who go around and tell everyone how great their surgery was, because again, in typical cases, these patients will have steamy corneas and they're not going to see well. It's going to take weeks for them to clear. With this technique, you will not have this. And this is truly a practice builder if you employ these techniques. So I hope this was helpful to you, and I thank you for your attention.